Good morning, everyone, and welcome to this February 11th edition of Meds Ed, the primary care education series brought to you by CareOregon and the CareOregon Pharmacy Department. My name is Paul Carson, Training and Development Specialist with the pharmacy team, and I'll be your host for Meds Ed this morning. We do these primary care education series about 6 times a year, rotating through different pieces of content and things that matter to folks who have a stake in the primary care universe. Let's go ahead and just do a little bit of housekeeping for everyone as we start things off here today. And again, you are at a very special session this morning that we've titled Xanax is the Only Thing That Works and Other Tales of Woe, Trauma-Informed Difficult Conversations Around Deprescribing. I know everybody is always very interested in CEU and CME, so let's just talk about that. It's important that you're all enrolled in this, so we have your email address. At the end of this session, later on today, I'm going to send out a survey to everybody who's an attendee. Very, very brief and simple. You just basically fill that out, and we'll make sure we get your CME and CEU hours back to you. We've got regular CME through the American Academy of Physicians. For those of you who are in more social work type occupations, we have CEUs as well. And these credits are also applicable over to folks from the Oregon Board of Pharmacy. So pretty much whatever you need, I think we got it, and you should be good. Let's talk learning objectives. Talk about where we're going to focus here today with our presenter, who we are incredibly fortunate to have. I don't know if anybody here attended Lydia Bartholow's session with us in November, but it was pretty spectacular. So I feel like we're ridiculously lucky to have her back here again to start things off for 2025. Here are the core learning objectives for the session here today. As participants, you'll be able to describe the trauma-informed paradigm as it relates to difficult conversations regarding controlled substances. You'll be able to list the elements of a trauma-informed difficult conversation. I'm sure we've all had some of those at some point or another. And you'll be able to apply a focused conversational roadmap in the clinical settings while maintaining clinical integrity and values. Seems like a lot, right? But you're going to be able to do it. Have no fear. So real quickly, before I introduce our presenter, we tend to not emphasize this as much as I think that we should in healthcare, but one of the most important aspects of improving outcomes for the people that we are serving is communication. It truly, truly is, because we hear people tell us all the time, it's on a good day, healthcare is like another language, and it can be a very interminable language and difficult to understand. And imagine if you are somebody who comes from a background of trauma and you've finally found something that works for you, right? You've been up and down things in terms of treatment, and you finally got something that you feel is working for you, and now the well-intentioned healthcare professional wants to take it away from you. And you're like, wait a minute, I was trying forever to find this, and now that I've got it, it's my life preserver. I don't want to give that up. What are the basic kinds of reactions that people exhibit when you try to take something away from them? And I think it's those kind of just simple cornerstones of communication dynamics that end up really muddling things up when we start talking about the field of deprescribing. So we're going to try to put as much of a human face on that today as possible. And nobody, I think, is better suited to do that than our key presenter here today. Lydia Bartholow, I'm going to throw all of your acronyms at the world here, Lydia. DNP, PMHNP, CARN-AP, FIAAN. Lydia is a doctorally prepared psychiatric nurse practitioner with a specialty in addiction medicine and trauma-informed care. She's the medical director of an emergency room that specializes in SUD-related crises in Portland, Oregon here, and is on faculty at University of California, San Francisco, as well as Oregon Health Science University. She speaks nationally on topics such as co-occurring disorders, harm reduction, and substance use disorder care system improvements, and is a fellow in the International Society of Addiction Nurses. She focuses all parts of her practice on radical public health, harm reduction, and anti-oppression work. Lydia lives in Oregon on Chinook, Cathlamet, Clackamas, and Calapooya land. and she's ready to go. I'm here to tell you, she's got a lot to share with us today. So please join me in welcoming the fabulous Lydia Bartholow. Lydia, take it away, my friend.
Thank you so much, Paul. It is so good to be back, and I always love your introductions. Thank you. That was so lovely. Good morning, everyone. Paul and Ian from Tech and I have been here since 7, and I think we're just sort of waking up, and I'm just so excited to dive in with all of you. I love giving this talk. I love talking a little bit about how to talk to our patients in trauma-informed ways about some of the most difficult things that we experience. And when I say difficult things that we experience, what I mean is that oftentimes in a clinical setting, we don't get a lot of training about how to have the conversations. So we get a lot of training about medications, we get training about diagnostics, we get training in assessment. If you're a behavioral health clinician, you should get many, many years of sort of understanding biopsychosocial structural forces. But oftentimes, no one spent time telling us exactly sort of how to deliver information. And so when I give this training, it's really about understanding that some of these difficult conversations that we have, especially around controlled substances, are some of the trickiest things that we do. And so I've tried to sort of pull together a couple different threads to create kind of a paradigm and a way of thinking about these conversations. And my hope for you guys is that it's really useful. A lot of the educational work I do is really, really conceptual. And this is very much meant to be translational. And when I say it's meant to be translational, what I mean is this is something that you should be able to just pivot and utilize clinically, kind of ASAP. This is not the kind of thing that is going to be conceptual and sort of like filters in on the side of your clinical world. This should be something that you can just take and then translate into everyday encounters with patients. At least that's my hope. Please give feedback if it feels otherwise, but what we're going for today is really like a very, very practical, translatable paradigm that you can just take and utilize with patients. And there may be things that aren't difficult conversations around controlled substances. It may be other situations in which you really, really need to set like a clear boundary, and you're going to think about the how and the why that you do it using some of the same sort of conceptualizations. So before we dive into the context, let me tell you guys a little bit about sort of how I got here. When I started clinical practice, it was back in 2012, and much of my work sort of came to be in the setting of the opioid overdose crisis. And we'll sort of get to this in a second, but when I started doing this work, it was very much a time period when we were understanding the risks, especially of co-prescribing opioids and benzodiazepines together. And so I came into practice and I had been trained in school to not utilize benzodiazepines regularly and to get people off of benzodiazepines. And then ultimately in those first couple years, I ended up doing clinical supervision for other new clinicians. So I was a new clinician and I was doing clinical supervision for other new clinicians. And over again, what I heard was that the hardest part of our job was saying no about medications that people felt really, really worked. And oftentimes do really work, and we'll come back to that. They really work in terms of thinking about experiential symptoms. People feel better right away when they're taking benzodiazepines. And so those conversations were some of the most challenging for me as a new clinician. And I also noticed that they were some of the most challenging for other clinicians. These were the things that would come up in clinical supervision kind of on a regular basis. And so that's sort of how I landed here. And I started thinking a lot about, okay, what are the things that are most challenging for me? And then what are the tools that I already have in terms of communication? And it became really clear to me that I could utilize sort of a paradigm around trauma-informed care to think about these difficult conversations. And so when we talk today, we're going to start with sort of a context. How and why was it that I was having these conversations so regularly? And then thinking about why those conversations are so difficult. And then we'll sort of pivot a little bit and we'll talk about trauma-informed care, thinking about trauma-informed care outside of this setting, and then how to translate some of those basic principles into this setting. And then we'll talk about what that really, really looks like, how that sort of, again, translates and how we can operationalize it right when we're with clients. So not conceptually, but really like, how do we operationalize it in a way that you can just utilize ASAP? And then we'll do that by looking at sort of a roadmap on this. And oftentimes in this presentation, people start asking questions about how and when to prescribe benzodiazepines and who's sort of appropriate for benzodiazepines. And I love to have that conversation. I love talking about benzos and thinking about benzos and who is appropriate for benzodiazepines. It's also not in this presentation. We'll probably get to it a little bit today, but this presentation is really about the conversations about benzodiazepines. It's much less, should we prescribe benzodiazepines? Are benzodiazepines good or bad? This presentation and the next sort of couple hours of material are about how to have conversations about medications like benzodiazepines, although it's pretty translatable to opioids, stimulants. Anytime there's a medication where we don't think the medication is safe for the person and the patient is pretty set on that medication, or even sort of situations. I use this pretty regularly. I utilize this framework pretty regularly in the emergency room, even when we're not talking about medications. So let's go ahead and dive in, and let's just think a little bit about sort of where we are. So I mentioned that I started thinking about this right around 2012 as I came into clinical practice. And I want us to all just think for a second. This is one of those times where I really wish that I could see the Q&A, but I just want us to think for a second about sort of where we were in 2012. So as I came into clinical practice, what were the big conversations we were having about controlled substances? And what will happen now is you'll put things in the Q&A, and then Paul will sort of translate it for me.
Nothing's coming through yet, my friend, but I'll keep an eye on things here if we do.
Okay. So when I moved into clinical practice, thinking about the opioid overdose epidemic was really at the forefront. We were moving into a new era, and we had just been sort of in an era in which we were recognizing that opioid overprescribing had gotten us into a lot of public health trouble. So opioid overprescribing, really with lots and lots of push from pharmaceutical money in an effort to garner more money for pharmaceutical companies, had done this enormous disservice to public health. We had lost communities and mothers and children to the opioid overdose crisis in the setting of overprescribing. And as we recognized that, right around 2012, we were really starting to pull back our opioid prescribing. And around this time, we were also seeing these public health trends that included opioid and benzodiazepine prescribing, where we saw that there was more and more overdoses where there was concurrent use of opioids and benzodiazepines. So around this time, we were having these sort of large conversations and these cultural shifts that included a lot of getting people off of benzodiazepines and off of opioids. And so when I started in public health sort of psychiatric practice, at the time I was practicing at Old Town Clinic, which is part of Central City Concern, part of my role was to get people off of benzodiazepines. And so I was having these conversations regularly. But this opioid overdose epidemic really was sort of in the background. And as we've been moving through this time period of the opioid overdose epidemic, and now we're in wave 3 that includes fentanyl and other synthetics, there's been a big push to think about the parallel for benzodiazepines. And the parallel here is we've got a controlled substance where there's a concern for an epidemic of misuse or risky use. There's so many concerns that are sort of lined up with opioids. Benzodiazepines can create tolerance, dependence. We know that over time, they can have side effects like depression, emotional blunting. There's some question if over time, if they actually cause dementia. That evidence is so tricky for me to sort of sort through. I mean, there's huge swaths of evidence that say that benzodiazepines, when used regularly and long-term, cause dementia. And then there's other evidence that really refutes that. So I think we're sort of in a gray area there. But overwhelmingly, we don't have any evidence that there's safe use of benzodiazepines past about 2 to 4 weeks. We have no evidence that says that these medications are safe. And we certainly have evidence that says that these medications allow for neuroadaptation, and that neuroadaptation most likely causes depression, again, emotional blunting, and may have some memory impairment as people age. And again, in thinking about the opioid overdose crisis, I think there became this really big concern for prescribing benzodiazepines. And not that we haven't had concern sort of over a long period of time, but got a much more heightened concern. And I'll see clinicians say like, well, benzodiazepines are the next opioid epidemic. So I'll see people sort of make these parallels between benzodiazepines and opioids. And it always is a little bit confusing for me because it's actually pretty hard to overdose just on benzodiazepines. If we think about fatal overdose, benzodiazepines are not something that often allow for a fatal overdose, and yet they do have a lot of risks. And so I think it makes sense that people are thinking about this sort of in the same way. And yet what happens then is we have these rapid conversations, these rapid titrations with patients, where patients often are then left feeling like they're not getting their needs met. So clinicians say, okay, this is really, really concerning. And then patients, again, feel like their needs just aren't being met. This is just a meme for humor. If you know me, you know that I love memes. Memes are my love language. You can send me memes really at any time, especially if they're psychiatric memes. And what we found is just patients were saying, hey, this is a medication that really, really worked for me in the past, and now you're telling me that I can't have this medication. And the meme says, only Xanax works for me, and if you've ever taken Xanax before, or you've talked to many patients, you'll see that Xanax really, really works, and it's immediate, so patients really know the difference. And then the provider's saying, hey, like the best I can do is hydroxyzine. And where that ends up for patients and for providers is we have what we call difficult conversations. Emotions run really, really high. Patients are saying, hey, my needs aren't being met. This medication really, really works for me. And you know, if you're a provider that's interested in doing sort of patient-centered care, you often go with what your patient wants on a regular basis, and sort of what you do regularly is you meet your patient's needs. And yet in these conversations, there are often ways in which we cannot meet our patients' needs. We cannot sort of align with them fully and give them the things that they're requesting. And it's so tricky for those of us that are practicing patient-centered care, because this is a place where the power imbalance really, really shows up. We want to be patient-centered, we want to be non-hierarchical, we want to be trauma-informed, although it's much harder to collaborate when there's things like controlled substances in the mix. Controlled substances, of course, bring up so much for us in terms of thinking about our licenses, in terms of thinking about time burden. And these conversations, they, for so many of us, end up having this huge emotional burden. And at least a couple years ago, when I was doing a lot of clinical supervision around these conversations, I just heard over and over again that these were the kinds of things that people felt like was burning them out. And overwhelmingly, people didn't feel like they went to school for many, many years to tell people no, they can't have the thing that makes them feel best. People went to school because they wanted to be of service. And so it created this real tension point where we felt like we weren't meeting patients' needs. And if we're not meeting patients' needs, that's one piece of the puzzle for getting us to burnout. And what the evidence says is that when there's difficult conversations, people either tend to get less clear or more emotional. So essentially, people get either more passive or more aggressive in these moments. And it's different for each of us. And I'm actually curious, and this is exciting because we have the time to do this today. And also, I want to know if the Q&A function is working for you all. I'd love to hear from you all if you think that you're someone that tends to get less clear. You get sort of vague, you make fewer clear statements, you get sort of like almost overly gentle where things get really, really nebulous, or if you're someone that gets more negatively emotional and almost even sort of aggressive in these moments. It's really, really common. Some of us, and I'll speak for myself here, have such a hard time saying no. We sort of have a nervous system that's really set up around people pleasing. We have such a hard time saying no that we're not going to be clear and direct in these moments. And then other people have a nervous system that's set up where when there's sort of a fight or flight, we go a little bit more towards fight, or we go a little bit more towards aggressive. How do you guys land? Think about it for a second. What's your sort of like neuronal network default here? Do you get less clear, or do you get a little bit more negatively emotional? Paul, are we getting anything?
Here comes a lot right now. This person shares that I definitely do both, but so much depends on the patient's response. Here's another person that says, I get less clear generally. I start to ramble and get more excitable. So both, eek. And this person shares that they get more passive. A lot of people are starting to answer here now. I definitely get less clear. Absolutely less clear and more negatively emotional because of burnout and having these conversations around prescribing over and over and over. Passive in the beginning and then aggressive. This person says somewhere in the middle. Leans towards emotional. Yeah.
Yeah. Okay. This is super useful. Most people have a neural network that like really is set up in one direction or another. I hear a lot of boths, which is good because it means that your neural networks are sort of engaging in multiple different things dependent on the patient and their presentation. And I just want to validate that it's so common. These kinds of responses where you get less clear, super common. No one trained you how to have these conversations, and it makes a lot of sense. You're going to default to that. Or more negatively emotional in relationship with the patient. Again, really, really common and very good to know what your default is. Very, very good for you to know where your default is. I'm so excited that we get to do this class this morning, and I'm so excited that I'm finally sort of waking up. This is a class that I often do in just an hour, and we actually have 2 full hours, 2.5 hours. Is that right, Paul? We've got 2.5 hours this morning.
You got 2 hours for the regular content, and then we have like some nice 30 minutes of Q&A interaction.
Yeah. So great. So that means that we really get to dive into like what happens for you all. So I want you guys to notice here what your default is, because we're going to come back around to that. And I hear a lot of you saying, okay, well, I do both a little bit. Notice sort of just what your default is. Are you someone that defaults to more passive or defaults to more aggressive in these moments? Where do you tend to go? And then we're going to come back around to that. Because I want to give you tools that work in either direction, but there's also going to be times in which I ask you to overcorrect yourself just ever so slightly when you're noticing yourself getting more passive or when you're noticing yourself getting more aggressive.
This person shared something really interesting, Lydia.
Yeah.
Kelly shared that they get more clinical delivering my script automatically.
Oh, interesting. So there's like a moment where you lose the humanness, which I think makes a lot of sense. And I also think that it's not necessarily a bad thing. In fact, part of what I'm going to ask you to do later is to really stay in the clinical role. So I don't know that I think it's a bad thing. And I think it's incredible noticing that maybe there's sort of, you walk into the room and you think a lot about the shared humanity. And then when these really difficult conversations come up, then we lose a tiny bit of that shared humanity, which is really about our burnout and is really both a driver and a consequence of burnout of working with patients. So I think that's really, really good insight. Yeah, thanks for that, Kelly. That's great. Oops. So I want to next know what your experience of declining benzodiazepines is. Tell me what it's like for you. And gosh, I wish we were all in a big room together. What's it like for you to decline benzodiazepines? And I'm not asking this time whether you get more passive or you get more aggressive in these moments, but sort of generally, what's it like? How bad does it suck? I want to hear all about it. And don't sort of limit yourselves here. Like, this is your time to just say how you really feel. This is not
Lydia,
the time.
Are clinicians' emotional defaults different, for example, like more passive or more aggressive when the patient is a person of color?
Oh, I love this question. And I want to make sure that we come back to it.
Okay.
I think it is such a good question. Because yeah, there's going to be a lot of content here that actually sort of relates to that. So let's loop back around to it. And for now, I just want to know what it's like. Like, how bad does it suck? And again, this is the moment where you don't have to show up being perfectly trauma informed, being anti-stigmatizing. Just let it all out for a moment. What's it like to over and over again decline benzodiazepine or stimulant or opioid requests?
These are the clients that will curse me and get aggressive in session.
Yep, these are the clients that will curse me and get aggressive. Absolutely.
And not my job. It's my job to pick up the pieces when the prescriber has to decline the prescription.
Okay.
I feel a sense of guilt, failure for not being able to provide a sense of immediate relief for the patient in such difficult times. And it's really hard because, like you said, you know it works for the patients, but you also know it's not safe. I get nervous every time because I hate saying no. I feel bad when I know they have been put on them for so long and really just want to keep using the medication that works for them. I worry about withdrawals for them. It's dreadful. I feel like I'm withholding something useful, but I worry about the risks and the professional liability with giving in.
Yeah. These are all such good comments and all show so much empathy. Everything I've heard so far is there's so much deep empathy here and really reflective of how this allows for burnout. We really want to show up for our patients. Sorry, Paul, go ahead.
No, not at all. This person shares that they're a psychologist who works on an integrated team. I don't prescribe, but many of my sessions involve clients being upset about my team member not prescribing medications they want. I feel very weird in these sessions as they want me to intervene and do something, but I just try to support their emotions and work on alternative strategies and ways they can communicate with their provider. Another person shares, I get frustrated that my clinical knowledge is dismissed by the patient. And this person is a social worker, and it seems to always suck without exception to have these conversations.
Wait, can you reread the last one, Paul? I couldn't quite understand it.
Oh, sorry. I'm not a prescriber, but I am a social worker. It seems to always suck without exception to have these conversations.
Yep. So I love that there's some non-prescribers here, and I'm just seeing how these waves move out beyond prescribers. These conversations are so hard for all of us to have. And it leaves the exam room, it leaves the prescriber's office and impacts so many members of the care team. That's sort of like how big and how sucky these are.
Yeah.
And again, I want to
this person
highlight how
says
much
they-
empathy.
This person says that it caused so much burnout that they stopped and left prescribing for 3 years.
Oh, wow. Caused so much burnout that they stopped and left prescribing for years.
It's tiring and frustrating because patients can't see any other option and are not willing to explore other options. But with some meds, I am frustrated because they really do work, and there has to be better options.
Yeah, absolutely.
Questioning my skills, whether I am doing the best harm reduction approach and whether I need more training and how to have a better therapeutic conversations around deprescribing. And then knowing they likely don't have the capacity for the medical understanding or risk from a clinical perspective, but frustrated that we can't be on the same page and feeling like I'm not doing my job. It's a fine line that I hate walking and dread the daily repetition.
I am just feeling so much how big this is for everyone here. Whenever I do this talk, I always hope it's useful, and I sometimes forget how heavy this is for people on a daily basis, especially in the primary care setting. This is just a daily burden that sucks. And again, I want to reflect how much empathy I heard here. Usually when I ask this question, there's a lot more anger. And I didn't hear a lot of anger. And it might be because Paul has such a nice, kind reading voice. But I didn't hear a lot of anger. I heard a little bit of anger, like patients are questioning my clinical judgment. And I'm wondering how many of you guys notice yourselves really angry in these moments? Which again, very, very common clinical response. There's anger.
I see a lot of folks mentioning they feel that they feel like they're really in a hard, awkward position and feel guilty, right? Here's a psychiatric nurse in an emergency room, right? Non-prescriber, but necessary to be a telephone and bearer of bad news.
Ooh, so hard.
And for these patients, it's as if they're being betrayed by our changing clinical knowledge.
Yeah.
Our growing understanding of these risks makes us want to restrict these meds. But meanwhile, the patient has become dependent on this med for years.
Yep. Yeah, absolutely. That is so well said. Our changing prescription patterns and our changing sort of cultural landscape and medical knowledge around these has made this such a hard place for patients to navigate. I think that in some ways we're coming out from a time period perspective, we're sort of coming out the other side where fewer patients expect these, but we're not there yet. And certainly when I started clinical practice, it was just the norm. For example, when I started clinical practice, just a couple of years earlier, it had been the norm if someone came in with depression and generalized anxiety disorder, or depression with like a tinge of anxiety, to start them on an SSRI and a benzodiazepine for 2 weeks. And then oftentimes the benzodiazepine just continued to be prescribed. It was just the norm that we prescribed these, and we've really shifted away from that. We've really shifted away from that as the norm, and it's really impacted our patients, and then we're expected to sort of like hold and navigate the emotional turmoil and the emotional burden of it, and it really is just so hard. So I'm not at all surprised that these are the kinds of feelings that come up for you in the midst of these conversations. And those kinds of feelings are exactly the sort of backdrop and the driver for this workshop. Understanding how hard the burden is and what a huge part of your work it is, that is the driver of why we talk about this and why it's so important to talk about this. How many of you feel like you got training in how to do this incredibly hard thing? I'm curious if anyone feels like they got training in it.
This person says that they feel it's likely a factor in their decision to shift their practice to peds.
Oh, interesting. Wow. Shifting to peds, yeah.
Yeah, not anger, but empathy with a tinge of frustration as I try to explain that best practice has changed in the past several years.
Yep. Yep.
And then this again, I see a lot of folks feeling in an awkward position or feeling guilty. I feel privileged discomfort that the tools I have personally to deal with anxiety, like yoga or massage or therapy, are not always accessible to my patients for whom it's too expensive.
Yeah, absolutely.
I've heard it all: begging, pleading, threatening to use street benzos, or threatening to report me to the board. Makes me feel more sad than angry.
I feel like I just wanted to like dive out there and hang out with all of you guys. Again, I'm so used to getting a lot more anger when I ask this, because I tell people like, hey, just like let it all hang out right now. Now is not the time to be trauma informed. And what I'm hearing from this crowd is just so much deep empathy for our patients. And I'm so appreciative of that. And it's such a good place. Either place is a good place to start. But acknowledging the feelings that you carry around these conversations is the perfect place to start as we move into how to have them better. Acknowledging how hard they are and recognizing that we want to have these conversations better, that is the perfect place to start. And so just deep gratitude to all of you for all of your empathy and really like showing up with your own feelings here. I am so appreciative that you shared your experience in declining, because again, I just saw how huge of a burden it was for you. And now I want to, or I should say is for you, now I want to pivot a little bit to thinking about the client experience. And it sounds to me like many of you are already thinking about this. It is very, very common on a national scale that when I'm talking about this, people aren't thinking about the client experience. You guys are already doing that, but so regularly, people are not thinking about the client experience. Indeed, I recently saw a comment in a national psychiatric provider Facebook group in which they said, I wish that there was a benzodiazepine police, where we could do something about patients who kept asking me for benzodiazepines and demanding benzodiazepines when I can't give them. And I thought that that was such a telling remark about the countertransference around these medications and clients who take them. So let's pivot to then thinking about client experience. And again, it sounds like this crowd is very sort of fluent in client experience, but it's really, really important for us to think about what clients experience in these conversations. So this idea around what clients experience, this comes from a focus group that Laura Hiesacker did in Southern Oregon, and this is probably about 15 years ago now. And it was in the setting of providers in Southern Oregon really decreasing their opioid prescriptions. So we understood that we were in an opioid overdose epidemic. Providers in Southern Oregon, from a public health perspective, were being asked to prescribe fewer and fewer opioids. And Laura said, well, what's it like for the patients to have these conversations? We know it's hard for providers, but what's it like for patients to have these conversations? And so she did these focus groups where she asked patients and then sort of distilled down what their experience was. And I just want to give a big shout out to Laura right now. She's a social worker in Southern Oregon who thought a lot about chronic pain. And so the driver for her in doing these focus groups was thinking about what it was like for patients with chronic pain to have these conversations. And the driver, why she did it, was to think about how we could do them better. And so much of my framework around this really comes from Laura. I think of Laura as this incredible mentor and thinking about how to do this differently and better. And when Laura did these focus groups, she was able to distill the client experience down, and that's what you see on the slide in front of you. So let's just go through these because I think each of them is so important. Patients, however we call them, reported that they were made to feel like they did something wrong. And this one feels so salient to me for a couple of reasons. One, who started this? Like, who started the opioid overprescribing epidemic? Who Who's the driver of that? And I don't mean like an individual, but sort of how did this come to be?
I think this is that moment where prescribers, somebody's saying, prescribers, big pharma.
Yeah, I mean, yes, 100%. So this is such an interesting moment because patients are saying, hey, I feel like now you're taking away these medications, or you're telling me I can't have these medications anymore. And yet, when I think about sort of where this started, this came from providers who were trying to do the right thing and were being misled and misinformed at a huge, like sort of a global level about what best practices were by people that were solely looking to garner more capital, right? And yet the trickle down, even though someone did do something very wrong here, the trickle down is that patients feel like they were made to do something wrong. And the sort of emotional context of being made to feel you did something wrong is shame. I did something wrong. I did something bad here. The emotional experience there is shame. And what we know about the emotional experience of shame is that it's not a place where behavior change can happen. Shame is not the place where change comes from when we think about what are drivers of change. So clients are made to feel like they did something wrong, which is a shame emotion. And shame is not the place where we can encourage change. Patients also reported that they were made to feel like a criminal or a drug addict. And I think this one is so interesting and telling. Remember when I said that I saw a post in a national Facebook group where someone said that we need a benzodiazepine police? Patients can feel that there's something here about relation to drug addiction. And we won't fully dive into this today, but when neuroadaptation starts, which is going to happen anytime someone is given a benzodiazepine, they're going to become dependent if they take it more than a couple weeks at a time, and they're going to build tolerance. And we have such a misconception of what addiction is, and we often conflate addiction with neuroadaptation and dependence, that then patients actually feel that they're being treated as a drug addict, often are treated as a quote unquote drug addict. And our cultural narrative around addiction is so intertwined with criminality that patients felt that they were being treated as a criminal or a drug addict. And this is absolutely true, I think, that oftentimes patients that felt like they got a lot of benefit from a benzodiazepine are treated as a criminal or a drug addict. Patients also reported that they felt they were being punished, that prescribing practices change over time, but that the person being most impacted by it and indeed being punished was the patient themselves. And that they were being talked down to. And this one to me sort of goes back to this idea that patients felt like they did something wrong and were being shamed in some way. They felt like they were being talked down to and weren't being treated as an equal with the provider. And I think what a lot of providers would say is, I'm fluent in the evidence around the risks of these medications. And as a medical provider, part of what I'm supposed to do is help people understand the risks of their healthcare choices. And what patients experienced is that I was being talked down to. And this one makes so much sense to me. Patients felt that they were being talked down to when they were being talked to about risks, because the power imbalance is so clear in that moment. And the patient experience of taking these medications and maybe the daily value of these medications for them gets lost when the provider is thinking about risks. So patients felt like they were being talked down to. And they often felt like they didn't understand why they were being forced to make decisions. forced to make these changes. And that we didn't have concern, clinicians didn't have concern for their pain and anxiety, only our policy. And this one really rang home for me. When I heard this, I remember the moment that Laura presented this to me. I remember it, and I remember it landing so intensely for me because this had been my out. I am sort of, my neural networks are set up wildly, anxiously attached. I'm sort of a people pleaser. I do not like conflict. I was raised by two hippies in very rural Colorado. I didn't grow up in a household where people had conflict. Indeed, I grew up in a household where people, you were supposed to sort of like meditate or like get happy when you had bad feelings, and you certainly wouldn't express bad feelings or any kind of conflict to the other people in the household. And so my go-to for telling patients that I wasn't going to prescribe benzodiazepines is I would say it was clinic policy. This had been my go-to for years. I didn't know how to have these conversations. They were incredibly hard for me, sort of from a personality perspective and from a clinical perspective. I didn't know how to maintain alliance with my patients and avoid that, avoid the conflict in the moment. And so what I would do is I would say, well, it's clinic policy. I would remove the onus from me and blame it on clinic policy. And yet what these focus groups from Laura were very clear about is that when we did that, what patients heard is that we cared about our policy or clinic policy more than we cared about them. And the same is true here for saying, my license is on the line. What patients then heard was like the policy or the license was more important than their daily experience of pain or anxiety or whatever sort of suffering they were experiencing. And so again, I remember the moment that Laura presented this to me because I remember that I thought I had been doing it really well. I thought if I talk about our policy, then I could maintain alliance with my patients, but I could show them that there was something sort of outside of me that was encouraging this to happen. And indeed, in some ways, that was very true. I mean, there were times early in my career where I really thought that benzodiazepine cessation would not be beneficial for a patient, but I really felt like our clinic policy said that I needed to cease the benzos. And so sometimes I was just being transparent, but oftentimes I was just avoiding a really, really hard conversation because it wasn't something that culturally or otherwise I was used to having. I was so not used to having these difficult conversations that saying it was our policy or it was my license was a really, really easy out for me. And it's interesting because I taught this class recently, and when I taught the class, someone said, yeah, well, you know, that really works for me. Saying that my license is on the line really, really works for me in talking to patients. And it works, especially if the patients care about me, which they do because we have a good alliance. And this made me feel so uncomfortable, this idea that if we had a good alliance and the patient cared about me, they would care about my license, and that was sort of the fix to these conversations. Can you guys think about why, and I'm a behavioral health provider, I'm a psychiatric provider, and so I might think about this a little bit differently than the person that shared it with me, who I think is a primary care provider, but can you guys think about from sort of a behavioral health perspective, why the idea that talking about my license, and if patients really care about me, then they'll care about my license, might feel so uncomfortable?
One person referenced like an inherent power imbalance that it kind of brings to mind for them.
Yeah, there's an inherent power difference there. Absolutely. Absolutely. And in that power difference, the expectation is that one person in the room is caring for the other person. Who is appropriate to care for the other person?
This person says ego.
Oh, interesting. There's some ego there.
We're putting our own well-being ahead of the patient in that situation.
Yeah.
And also transference.
Yeah, so there's some transference there, and we're putting our own well-being ahead of the patient. So this was fascinating to me that the provider said, well, if they really care about me, then they're going to care when I say my license is on the line for prescribing this. I thought it was fascinating because the appropriate way for that relationship to look, sort of what's most clinically indicated, is that one person is caring about the other person and not the other direction. And it doesn't mean that we don't have these moments of humanity with our patients and that we don't decrease the hierarchy, but the appropriate clinical relationship is that one person is caring for the other. When I say we have to stop doing this for my license, what that says is that I am elevating my needs, despite the fact that we have a clinical relationship in which I'm supposed to care for you. I'm elevating my needs up to the level of your needs. And it may work very, very well in some settings with some patients. And as a behavioral health provider, in my mind, that's unethical.
You got a lot of folks weighing in on this one, Lydia.
Okay, I want to hear.
A chorus of folks saying that all of a sudden the relationship isn't patient focused or patient centered anymore.
Yeah,
right?
Exactly.
We're treating them. We're
Yep.
treating them, not the other way around. The onus is on us, not on them. They're the one crisis seeking support. And this feels very much the opposite. As clinicians, we never want to ask patients for help. We're there to help them, not the other way around. And if they care about our license, it feels like we're asking them for a favor or becoming indebted to them, which we don't want to do. So I think that really struck a nerve.
Yeah, absolutely. And so it's not on this slide, but I put it in the same bucket as thinking about our policy. What that means is that we're going around our concern, and indeed we're moving outside of the relationship that should be about our care for them and flipping it back onto what works for us, what our policy or my license says this. And that's almost never appropriate. Slightly more appropriate in a primary care setting, although I would still argue that even then, that relationship that has to do with care should always have care that goes from the provider to the patient. That's the sort of cascade of tending to that's appropriate in a clinical relationship. Provider to patient, regardless of the kind of provider. And grounding us back in the client experience, clients experience those moments as we don't care about them, we just care about our license or we care about the policy. And so when I give you tools today, I want to explicitly give you tools that are going to help, and they're not going to fully take away, but help clients from feeling that they did something wrong, that they were made to feel like a criminal or a drug addict, that they felt punished, that they felt talked down to, or that our policy or our license was more important. My hope is to give you some tools so that clients don't leave the office feeling this way. We can't make people feel anything, but again, my hope is that we can do this in a better way where clients don't have this experience and that you feel less burned out by these conversations. And I want to just highlight here how important stigma is. So you'll remember that one of the things that clients experience is that they were made to feel like a criminal or a drug addict. And I just want to take a minute and hang out and think about stigma. Substance use disorders are deeply stigmatized, and the number one predictor of people accessing services for substance use disorders is the experience of stigma from care providers. So people with substance use disorders delay care secondary to experiences of stigma. And so if we think that someone has moved into the realm of having a use disorder related to some of these substances, away from just neuroadaptation, which again is going to happen all the time, if someone's moved into having functional impairment, which means that they have a substance use disorder, the thing that we most want is for them to get treatment. And yet, if what they experience in these conversations with us is stigma, they're actually less likely to get treatment. So we want to be sort of doubly concerned that people don't experience stigma in these conversations, especially when and if we are concerned that they moved into the realm of having a substance use disorder. This one is particularly important and allows me to sort of loop back around to something that was said earlier about tending to people of color. So in these client experiences, clients felt that they were being treated like a criminal or a drug addict, and this was client language. We wouldn't use the term drug addict, or at least I hope that we wouldn't. We might say someone with a substance use disorder. And so I want us to just think about stigma and what overlaps stigma around substance use disorders when it comes to folks of color. Where is that sort of like overlapping or sort of exaggerated experience? What might our clients of color experience in these moments? For very good reason, by the way. I use the word exaggerated, but what I mean is it's overlapping and it's going to be sort of accentuated, not that the experience is an exaggeration. Anything coming up, Paul?
And here we are starting to get some through here. Assumption that they are addicts is one that gets shared here a lot. We have some more come through here. The role as providers to care for the patient and client. Also, my license isn't just my ability to care for that patient, but also my ability to care for all my other patients, which is asking that person to care not only to take on my role of managing my license and availability, but asking them to take on my role to care for my entire patient client base.
Yeah. Oh, that's so well said.
Racism, this person puts in.
Yep. The experience of racism in a clinical setting, yeah, for folks of color, absolutely. Well, yeah, let's just start with that then. So our folks of color are more likely to experience these conversations as being treated like a criminal or an addict. And again, this is there's very good reason here. Our cultural narratives are so deeply intertwining of the ideas of who a person with a substance use disorder is or who a criminal is. Our cultural narratives are so deep around criminality, race, and substance use disorders being intertwined. This goes back to 1950s with Harry Anslinger, and even prior to that, where we have these cultural stories we tell. The people of color are more likely to be criminals. People of color are more likely to have a substance use disorder. And how that translates is we might be over here sitting and sort of thinking about, and let me just highlight for a second that we know because of structural violence that most healthcare providers tend to be sort of dominant culture. It's much less likely for healthcare providers to be folks of color, which really greatly influences our patients who are people of color and have culturally incongruent care. And so when I'm talking about this, I'm sort of assuming that there's a white provider and a person of color as the patient, not because that is the way that it is, but because structural violence sets up our care paradigms to just reinforce that over and over again by way of structural violence, which means that white providers are more likely to then believe that patients of color are criminals or addicts somewhere in their head. That cultural sort of narrative is so deep, and folks of color are going to experience it. Oh, I'm being treated like an addict, or I'm being treated like a criminal. So we want to be really, really careful here that that stigma doesn't get compounded in thinking about other marginalized identities. So
this person shares too, right on top of that, right? They say that they've had many patients of color say that they feel dismissed and that they're not heard. They're not heard.
Yeah, absolutely. And indeed, the evidence says that providers spend 6 minutes less average when patients are not the same ethnicity or race as they are. And 6 minutes, it's weird when you hear it first, you're like, oh, that doesn't sound like a whole lot. But if you think about the average primary care visit being between 15 and 20 minutes, and the average psychiatric visit being like 30-ish minutes, right? 6 minutes is actually a lot of time, and it means patients of color get pretty significantly fewer amount of care. So yeah, our patients of color are getting less time with us, which means that that experience that they are less heard is likely to have some grounding in truth, right? Our patients of color are experiencing, I'm not being heard as much, and there probably is some truth there. And I don't think it's intentional, much like it's not intentional for us to bring our cultural narratives into the clinical setting, but it happens. It's the nature of racism. It's the nature of white supremacy. Those narratives get deeply embedded in us, and they will end up shaping those clinical encounters. All right, so on that sort of very heavy note, we've been talking about the provider experience, which we've acknowledged is really, really heavy. I heard you guys say that this was incredibly hard for you, that there's guilt and there's this deep empathy and there's this sorrow, and that some of you even changed your practices, changed the population that you treated because this became so burdensome for you and like sort of embedded in your nervous system as something that was really, really hard. And then we pivoted and we talked about how hard this is for patients and how much stigma there is here, how easy it is to avoid conversations with patients, and then ultimately end up harming them by saying things like, oh, you know, it's our policy. And so I just want to sort of sit there for a second and think about how hard these conversations are. And the tools that I want to give you today, they don't make these like magically easy. The tools I'm going to give you today make these easier, make these more trauma-informed and more patient-centered. And my hope is they also decrease burden for you. They decrease how hard it feels for you. Again, it's not gonna take away all the hardness. It's not going to become cheery and rosy because we've got some new tools. And the tools that I want to give you, they all come from trauma-informed care. So in thinking about how to have these conversations better, there's a couple of sort of key drivers for me as I thought about, okay, well, I'm having a hard time with these conversations. Other people are having a hard time with these conversations. What do I need to do differently? And how do I start to think about them? And there were a couple of key people that really influenced me. One was Laura Hiesecker. Again, she's a social worker down in Southern Oregon. And she had been doing a lot of work around opioid prescribing in the primary care setting and what that was like for providers and what that was like for patients. And the other person that really sort of shaped my thinking around this was, oh my gosh, I'm forgetting his name right now. Holy smokes. You guys are going to be able to tell me his name. He was the medical director of addiction medicine at Kaiser for many years. He has not been the medical director for the last couple years. I'll think of his name in a second. He was incredibly instrumental in sort of how I thought about this. And so I use both some concepts from Laura Hiesecker and concepts from the medical director of addiction medicine over at Kaiser for many years. And then what I sort of individually pulled in was a real commitment to trauma-informed care. And I want to think a little bit and talk a little bit about sort of how I conceptualize trauma-informed care in thinking about these conversations. So trauma-informed care has 6 key principles, and I want to come back to those principles, but I want to just think for a second about trauma-informed care and what it is, and specifically what it is that is not trauma-specific care. I will often tell people that my specialty is in trauma-informed care, and the first thing I hear is, oh, so like you do trauma therapy. And I think of trauma therapy as being trauma-specific care and being in some ways very separate from trauma-informed care. Trauma-specific care is when we address one patient or maybe a small group, like we're doing Seeking Safety or something, that has trauma sequelae symptomatology. Doesn't mean they have a diagnosis of PTSD, but means that we often have identified that there is maybe a big T trauma, maybe a little t, but more regularly there's a big T trauma. And we are addressing trauma sequelae with clinical interventions. We might use something like EMDR, or I'm prescribing a medication like Prazosin for nightmares. And we're developing specialty services that are designed, there's a treatment plan around an individual client. And that trauma-specific care is really what we do when we're with the patient, which is separate from trauma-informed care, which is where we think about clinical systems, so workflows, signage, continuity of providers, the way we set up our furniture in an office, or how we ask a set of clinical questions, maybe how we even do our intake paperwork. That for me goes under the bucket of trauma-informed care. Trauma-informed care is all about how we address client and staff experiences, again, of everyday clinical services or designs or events. So setting up the office, that's just an everyday thing, but we can do it from a trauma-informed lens. And in trauma-informed care, separate from trauma-specific care, we don't address one patient. We just assume that everyone we see has experienced some form of trauma and adversity, and that best practices assumes that. So for example, the way that we might set up our office, we don't change the office configuration based on saying, oh, you know, the next patient that I see has a history of trauma, so I'm going to change and I'm going to put the chair closer to the door for them because I know they have a history of trauma and it makes them feel safer to be closer to the door. What we might do with trauma-informed care is we might say, you know, I'm going to let the patient sit closest to the door because I know that when people have a history of trauma, they often feel safer closest to the door. And I'm just going to assume that all of my patients have a history of trauma because, especially in behavioral health, but across healthcare, we know that people are more likely to seek services and more likely to seek behavioral health services or have complex needs in primary care if they have a history in trauma. So I'm going to assume that my chair should just hang out by the door and all of my patients are going to be closest to the door. That's just an example of trauma-informed care in terms of the assumption that everyone we serve has experienced trauma. We think of it as universal precautions. We just assume this. And it's the how of what we do. Trauma-specific care is the what of what we do. Okay, I'm going to do EMDR. I'm going to prescribe Prazosin. Trauma-informed care is saying, oh, you know, everyone has intake paperwork that they have to do. Let me think about best practices for intake paperwork, assuming that the people I'm serving have a history of trauma. What might we want intake paperwork to look like? I remember a time in my life when I was having a lot of sort of chronic health challenges, and I was going to see a naturopathic provider, and it was like a specialty naturopath that had been referred to me as like sort of the best in the area for the specific health challenge I was having. And so I downloaded the intake packet, and it was huge. It was this huge intake packet. And just on the very first page, it said, the first thing I need you to do as a patient is I need you to agree that if I suggest it, you'll stop eating gluten, and that if you can't stop eating gluten, you'll be discharged from my practice. And I think it was like gluten and something else. I'm not trying to make jokes about gluten-free diets here. So forget the gluten part. It was the part that said, if I suggest this and you don't do it, you will be discharged. And it was the very first thing that I was signing. And I just want you guys to think about what that experience was like for me. I always love talking about myself and my experiences. It's like part of why I go to therapy every week. But just for a second, let's all talk about me and my experiences. What do you guys think that was like for me? First page of the intake paperwork.
It's like, you will do what we say. We tell you and you listen, Lydia.
You're going to do what we say. We tell you what to do and you listen.
We know better.
Absolutely. What's that?
We know better, Lydia.
Yeah, Paul knows better. What else do you guys think it was like for me?
That would make me very anxious, this person says. Power dynamic, this person says.
Okay, anxiety producing, power dynamic.
Here's a good phrase, provider domination.
Provider domination.
And it's invalidating to your personal experience.
It's invalidating to my personal experience. Yep.
Now I really want to eat some gluten, this person says. Welcome to the clinic, now F off, this person says.
Welcome to the clinic, now F off.
I would have been really angry, this person says, and taking away all of your power from the start.
Taking away all of my power from the very start.
And I like this one. I would immediately go into defensiveness and rebelliousness.
Right?
Shame, jolting and fearful. You were being told you had no choice in the matter and giving up your autonomy or choices in life. Treating you like a child, feeling like you have no control over a chronic condition if you don't comply. Ooh. Immediately imposes a power over dynamic.
Totally.
Wow.
Yeah.
Shame.
Yep. Shame, anxiety, all those things. That's all of what I felt.
I'm imagining myself doing that paperwork as a patient and just having a slew of questions in my mind. Can I do this? Do I even want to do this? Would I just lie about it?
Ooh, would I just lie about it? Fascinating. So many of us, I love this one too, because so many of us lie to our care providers, and yet we have a cultural narrative that a part of addiction is lying. And yet most of us, to avoid shame with healthcare providers, lie and minimize. I know I do. Holy smokes. Absolutely.
Yeah, we talked about that in November. Remember flossing? That's the one that we yeah, floss all the time.
Yeah, I floss every day. Totally.
This would make me wonder if the provider has a fixed belief that gluten is the source of all problems and question her judgment. Like your illness has been brought on or continues by your unwillingness to change.
Yeah. So, what was the point of me sharing about that intake paperwork with you guys? Like, why was it important to think about that intake paperwork just ever so briefly?
They're straight up denying your opportunity to learn why they would recommend it.
Yeah, absolutely. Yeah, definitely.
It's an example of not trauma-informed care.
Yeah, it's an example of not trauma-informed care. I mean, I just use it as like this sort of egregious example of how we do things, right? This didn't have anything to do with trauma. It didn't ask me if I had a history of trauma. It didn't ask me my ACEs. And yet the very first piece of paperwork that I was being asked to do for a clinic actually made me feel like I had done something wrong. It made it seem like my relationship to the provider would be in jeopardy if I couldn't comply with them. And so it's just an example of when we're doing trauma-informed care, we're thinking about all the minutia and how it makes client and staff feel, and specifically thinking, what would it be like for someone with a history of trauma? What would it be like for someone with a history of trauma if they got a clinical first page of a clinical intake paperwork that makes them feel ashamed or produces anxiety? What would it be like?
This person says that you shared it to show that things that we think are little, like paperwork, can have a real effect on the patient's mindset when we enter the exam room.
Yeah, I love it. That's exactly right.
And then this is what patients are being told about pain meds and benzos.
This is what patients are being told about pain meds and benzos. Absolutely. Yes, the parallels there are huge and shows so much about how the how of what we do, so the how we have these conversations or how we set up our furniture or how we do our intake paperwork can transform the patient experience to be one that feels much safer, much more inviting, and much less re-traumatizing. And that's what trauma-informed care is all about. And it turns out trauma-informed care, when you do these things, which we're about to talk through, when you do these things, it's incredibly evidence-based. You increase retention, you decrease dropout rates, you improve patient outcomes, you improve patient experiences, and you have improved staff experiences and decreased staff burnout. And one of the things I want you guys to get from today is to improve your own experiences. I want to improve patient experiences, but I also don't want you guys to feel so crappy. You guys are the backbone of patients getting good care. All of you, if you've shown up today, it means that you have a commitment to patients getting high quality care. And I don't want you guys to be burned out in the same way that I don't want patients to feel re-traumatized in the healthcare setting. So when I say it's the how of what we do, I want to go through how we think about changing our systems. When I say, we're going to change our intake paperwork, let's just take intake paperwork as an example because I mentioned it. What I mean is that we're going to think about what we need to gather in intake paperwork, and then we're going to see if we can do all of those things in a way that pulls in the principles of trauma-informed care. So, can we design our intake paperwork to ensure that patients feel more safe, that their experience of safety is increased? And when I say safe, I mean physical safety, but also their emotional safety. Are there things in intake paperwork that we can do to encourage an experience of safety? What do you guys think? Can we change our intake paperwork to be more safe feeling? The answer is yes, we can. There is always things we can do to be more safe feeling. We can start our intake paperwork by saying something like, I'm so glad you're here. I can't wait to be of service to you. Or I like providing care that looks like this. I'm so glad you're here. I would like feedback on the care, something like that, right? There are things that we can do to change our intake paperwork to make them feel safer. The next one is transparency. Changing our intake paperwork and saying, what could we do on this intake paperwork to make it feel more transparent? Trauma-informed care asks for trustworthiness and transparency, and specifically, I want to highlight transparency here. Are there things that we can do here in intake paperwork to be more transparent? And so including transparency in intake paperwork might be like talking about what happens if, I'm trying to think of a good example for intake paperwork transparency. It might be as simple as saying, here are my hours. Outside of these hours, here's who you would contact. Just being transparent that you're not always available to provide care, and here are other options that someone has. It's pretty dang hard to include peer support in your intake paperwork, except I would always say peers should have some piece. If you've got peers in your healthcare system, peers should have say in what that intake paperwork looks like. Maybe they want to have something in the intake paperwork. If you can include the voice of peers, you always want to do it. And then is there something in that intake paperwork that you can make more collaborative, more mutual, less sort of less focused on the power dynamic? I was so impressed with how many of you said that you noticed a huge power dynamic in the gluten front sheet. You saw a power dynamic immediately. And so what would it be like to have intake paperwork that decrease the power dynamic? Is there anything that you guys can think of that would decrease the power dynamic and create collaboration and mutuality? Can you guys just think of an example kind of right off the bat?
Acknowledge that it's okay if the paperwork is incomplete and allow patients to ask questions about the paperwork.
Ooh, acknowledge that it's okay if it's incomplete and say, we'll have time to talk about this. Yeah, absolutely. Absolutely. Hey, it's okay if you didn't get this done. We can talk about this. Definitely.
I just love the first thing you said, right? That it just applies to so many different environments. I'm so glad you're here. I'm excited to provide care for you. I mean, it's just like, that's so welcoming. That just like, it kind of, it's sending a message of delightedness, right? Which is just, I mean, that makes, you talk about, how you have to have rapport to really get anywhere, right? And that is rapport building on an epic scale, something like that. It's lovely.
Yeah, the I'm so glad you're here. I'm so glad you're safe is something that I say over and over again in the emergency room. And you would be amazed at the way in which people's faces soften. I'm so glad you're here and I'm so glad you're safe. And folks in the substance use ED, their face softens and we have this incredible moment of humanity between the two of us. So just the simple, I'm glad you're here. I'm excited to be of service to you. Huge. The other thing that I would suggest for collaboration and mutuality in intake paperwork is including a place on intake paperwork where you say, how can I be a better care provider to you? And you have open-ended questions about how you can be a better care provider. That is the essence of collaboration. How can I include your voice in this document? I need to gather some information, but one piece of information is, what do you need from me? That's the kind of collaboration we're looking for in trauma-informed care. And that's also the kind of collaboration that also offers voice and choice. When we do trauma-informed care, we want to offer space for voice and choice, not just here's the medical practice I have, but also where are your choices in this medical care? Where are your voices? And indeed, I think this is part of why talking about benzodiazepines or other controlled substances is so tricky, because oftentimes we can't allow a lot of voice and choice. It's a place where we want to, and part of the sort of rub, the emotional burden here comes from the lack of voice and choice that clients feel and that we feel for them. This is a place where I cannot be collaborative with you. It's really, really tricky. And then finally, the sixth principle of trauma-informed care is what SAMHSA historically has called cultural, historical, and gender issues. There is a pivot now within SAMHSA to not talk about this as cultural, historical, and gender issues, but to simply call it structural violence, tending to structural violence. And do you guys know that term? I realized earlier I used it, but I hadn't maybe like sort of flushed it out. What does that mean when SAMHSA says tending to structural violence as principle 6 of trauma-informed care? What are they getting at? Anybody know what structural violence is? Now there's silence and I'm thinking about gluten. So I'm just sort of over here like daydreaming about croissants.
A couple folks kind of continued talking about making the forms friendlier question.
Mm-hmm.
Here, Lydia. This was, I thought, a good quote. You're an expert on your body, so I want to rely on that expertise to help treat you.
Yeah, totally. You're the expert.
Yeah. And, state that the responses are optional and confidential, and maybe have a box that says prefer not to discuss. And,
Ooh, yeah,
instead of just
example.
check boxes, have some lines for more context or more optional.
Yep.
Optional.
That's a great way
answers.
to be collaborative. Yeah, totally. Yeah. And I think there's just like a slight lag. And so I'll go ahead and I'll define structural violence. But I think some answers around structural violence are likely to sort of pop up. Structural violence is acknowledging that people that come into care often have large systems and structures that have influenced their health care and their health outcomes that are often so sort of like structural and invisible on the day-to-day. So thinking about racism, thinking about poverty, thinking about transphobia or misogyny. The idea of thinking about structural violence in the context of trauma-informed care is recognizing that trauma is not always just a big T. It doesn't just mean you experienced one large traumatic event. It means that actually there are structures that have impacted health and wellness over time and allowed people to not get their needs met. Structural violence is really saying, hey, there's a way in which structures of racism, poverty, transphobia, really make it so people's basic needs aren't met. And indeed, we know from the newer neuroscience that actually daily experiences of oppression, daily experiences of microaggressions is incredibly hard on the body. We call it allostatic load. So when SAMHSA talks about structural violence as being principle 6 of trauma-informed care, what they're really calling out here is saying, we also want to think about the global experience that someone is having when they come into our care. So we've already done this a little bit today, which is to say, hey, these conversations are really, really hard. Patients are going to feel stigmatized. They're going to feel criminalized. And this may be especially true for our patients of color. Already marginalized, they may experience this stigma in 2 ways, which makes it overlapping and intersectional. So the idea of thinking about structural violence and trauma-informed care is saying, hey, we're also going to think about other traumas that people experience in their daily life that's not maybe going to show up on their ACEs score, but does influence their health and does influence their experience of trauma and healthcare. So that's what they're calling out when they talk about structural violence. And so now we've done the 6 principles of trauma-informed care. And what I want to do next is I want to translate that into pulling in safety, transparency, peers if possible, collaboration and mutuality, and empowerment, voice and choice, as well as structural violence, into thinking about these really, really hard conversations that we're having with patients. So the idea is, and just to sort of recap where we've been, we talked about what it's like to have these conversations for you all, what it's like to have these conversations for the patients. And then we've said, okay, we're going to utilize a trauma-informed care paradigm to think about improving these conversations so that they are less burdensome on patients, less re-traumatizing for patients, and less burdensome for us. So that's where we are right now. So we're going to actually start to look at the roadmap of sort of how to have these trauma-informed conversations. And as we look at the roadmap, I want us to sort of start by thinking about conversations that are sort of the beginning stages where the difficulty is not incredible yet. So I'm going to start with when you're just starting to have these conversations with folks, you're just starting to have these conversations with patients in your office. I'm going to start there, and then we will sort of ramp up as we think about those conversations getting more and more difficult. I will give different levels of intervention based on how hard the conversation is. So we're going to start just with that sort of initial conversation where we're starting to think about talking to someone and we're introducing the idea that we either are not going to prescribe a medication or we may need to taper a medication. And the place to start is always validation and education. Before we sort of dive into some of the more intensive, incredibly kind boundaries that I want to review, these conversations always start with validation and education. And we're going to pull in some motivational interviewing here, and I'll give you a couple of very concrete motivational interviewing skills to utilize. So I think of validation and education as the precursor to the difficult conversations. And of course, these are the conversations you should have with everyone. When we're talking about benzodiazepines, when you're going to taper or decline. And I just want us to think for a second, again, sort of going back to the patient experience, what is the patient experience of us talking about either taking away or not refilling or not starting again or not starting for the first time a medication that they think is helpful, or that their mom has given them before and it was really helpful, or that they've heard was really helpful? What's the patient experience of that? You guys, my caffeine is running out. We still have an hour and a half left and I'm out of caffeine. Things might get a little bit slippery from here on out.
You do not act undercaffeinated. I'll just say that.
Okay, good.
I think you're fine.
Okay, good. So in these moments, patients are going to be in what we call sympathetic activation. This is a moment where a patient is going to be feeling that there is a threat. They're often going to be experiencing that there is some kind of threat. And then all of the things that we talked about earlier in terms of feeling ashamed that they did something wrong. And there's a pretty real threat here, right? You are either going to take away or deny something that they feel is useful. So I want us to sort of just keep in the background that patients are going to experience these conversations as exceptionally threatening and threatening to their safety. And so one of the first things that we can do to lessen that threat experience is just to validate. And I'm hoping that you guys can tell me some of the things that you say in your clinical practice to validate patients in these moments. Here's some of the ones I do, and I'll let you guys know, I'll tell you guys these while you guys populate some of the ones you use in clinical practice, because I'm sure you probably, most of you do this already. You validate. Things are hard, you're gonna validate. Validation, a little bit different from affirmation, and is all about tending to the feeling and seeing it, making the feeling feel seen and heard, a moment of humanity. Hey, I know this can be really, really scary, or it's really hard to make changes like this. I also struggle with big changes. I think everyone does. It's normal when there's big changes to really, really struggle with it. Or even you feel like this medication really helps. It makes sense that you would struggle with a change to it. Just this idea that you're validating the emotion that's there. This is really scary or hard or challenging in some way. I see that emotion and I'm going to name it and let you know that I see it. So very first thing, just validate. This is really hard.
This person says, yes, that is a very effective, powerful medicine.
Yes, validation is an incredibly effective, powerful medicine. It really is. And it's always so useful to think about how powerful validation is whenever someone doesn't validate and instead problem solves or tells you that you should just like get over it or consider the silver lining. I love my dad in so many ways. There are so many great things about my dad, but I learned so long ago to not complain to him. Because my dad will do this. And I'm always like, oh, this is why we validate. So I'll be like, oh, I don't like my job. Oh my God, my job is so hard. And my dad's like, well, you know, some people don't have a job. Or this is the best one. Well, you could quit. I'm sure you could find a different job. It's so wildly invisibilizing. And I love that someone said it's powerful medicine to validate, because when I'm complaining to my dad about my job, I just want to be validated and seen, right? Our patients want to be validated and seen. It's incredible medicine to be present with them, this like moment of humanity where we see that it's such a challenge. We see what they're doing. We see how the sort of difficult context of their lives, or how much they're navigating, or how much anxiety they're managing on a day-to-day basis. And we just validate it and we're present with it. We're not going to try to fix it in this moment. We just see it and tend to it. Any other suggestions coming through, Paul, on how to validate in these moments?
I know that this is really frustrating.
I know this is frustrating.
Yeah, benzos are a double-edged sword. They're extremely effective, but can be habit-forming and risky with long-term use.
Yeah, and that one, the one that says benzos are a double-edged sword, they're this and they're this, I really like it. That goes under education. Validation is not telling anyone anything yet, except that you see their feeling. So let's dive into education. But before you do education, I would always try to validate and then also do some validation after the education. Do more than you think you need to a validation. And then the education, I'm going to ask you guys to do it in a really, really specific way. Remember when patients said that one of their experiences was that they felt like they were being talked down to? I want to give you a tool that comes straight from motivational interviewing, and it avoids the experience mostly, not entirely, but it helps to sort of buffer the experience of being talked down to. It is elicit, provide, elicit. Some people in motivational interviewing call this ask, tell, ask. And I think of it as the best way to provide all patient education, but it's especially imperative in these really high stakes, difficult conversations where we know patients experience being sort of invisibilized and their suffering has been invisibilized, and that they're being talked down to. So for elicit, provide, elicit, the magic is 3 parts. You first ask permission to teach. Would it be okay with you if I tell you a little bit about what we know about benzodiazepines? Hey, is it okay with you if I review with you some of the medical literature about the risks of benzodiazepines? So before you say anything, you get what we call a micro consent. They don't have to sign a piece of paper at the front desk saying that it's okay to talk about benzodiazepines, but you get a micro consent where you say, hey, is it okay if we talk about this? And often in that initial elicit, we get a micro consent. Hey, is it all right if I tell you a little bit about what we know about this? But also you might want to ask what people already know. So many times patients tell me that they know so much more than providers, and they do have so much more knowledge in their experience. And so we want to know what they know and what their experience is before we dive into what we know. We want to build on past knowledge or correct it if there's something there that we can build or correct on, and then get permission to share. My favorite story about this, remember I told you guys I kind of love talking about my own experiences. My favorite story of this is the time that I went out to eat with like an old college friend of my ex and my co-parent. We all went out to eat, and the old college friend had like recently found CrossFit and was just really, really into CrossFit. And so he started telling me all about CrossFit and its benefits. And he was telling me about how CrossFit like is just so good for you. It really like increases your cortisol levels. Cortisol is like that thing that like makes you feel good and makes you feel like you can solve problems, and how CrossFit really decreases serotonin. And that's really good because serotonin is like this inflammatory stress hormone, and like you really like need to get it out of your body. And like CrossFit's really good because it'll decrease serotonin. And if you're sort of like tuned in and listening, you'll realize that he got like some basic neurochemical and neurobiology concepts completely wrong. And if he had just asked a little bit about what I already knew, that conversation would have been so much less embarrassing for him. And indeed, if he could have said like, hey, I'm learning all this cool stuff about CrossFit, would it be okay if I share with you a little bit about CrossFit? I would have enjoyed the conversation much more. But instead, he dove into telling me about his new excitement around CrossFit, and then was like really, really wrong around some really basic biochemical concepts. And so I think about that all the time when I'm with patients. I'm like, I don't know what they know. And also, are they ready to talk about this? From motivational interviewing, if they don't say yes in that micro consent, although 99% of the time people are going to say yes, if they don't say yes in that micro consent moment, then I'm barking up the wrong tree. I am talking to them about the wrong thing. So the very first thing we do before we educate, before we provide any material, is we elicit. Is it okay if we talk about this? Tell me a little bit about what you know about this already. Hey, is it okay with you if we talk a little bit about benzodiazepines? I noticed that you've been on benzodiazepines for several years now, and I'm wondering if anyone's ever talked to you about benzodiazepines and what we know are some of the long-term risks of them. That's what that might look like in clinical practice. After you elicit and you get that micro consent and you have a little bit of an understanding about what they already know, then you can provide the education. But here's the thing, you're not going to provide the education as you usually would. You are going to provide it in a totally neutral, not person-specific way. So you're going to provide the education in a way that says what we know about benzodiazepines for everyone is XYZ versus benzodiazepines for you could cause dementia. Or when you take benzodiazepines with this thing, I'm noticing this. What do you think is beneficial about not tying it yet to the patient? When you provide the education and you don't yet say you just totally neutral, not patient-specific information. What does that allow for?
Here we go. Less immediate defensiveness.
Bingo! Oh my gosh, the first person got it. Absolutely. Less immediate defensiveness. This information is not yet as threatening. We have already made it less threatening by saying, hey, I want you to integrate this information, but as of right now, I'm not directing this specifically at you, which means you're going to repel away less. This is like motivational interviewing sort of 101. This idea that if we don't push, so if we push people, they're going to repel away. And especially in these conversations, what we want is for people to lean in and to engage in the relationship and the conversation more. So if we provide neutral, non-judgmental, not specific yet information, patients actually can sort of integrate the information, hear it, and sit with it, versus immediate defensiveness. Oh, this is a threat to me, so I'm going to repel that idea. Oh, okay. Here's the thing. And then you get to ask how the information integrates for the patient. And this one's always tricky. I always struggle with like how to do that. But the conversation might look something like this. Hey, would it be okay with you if I tell you a little bit about benzodiazepines and what the medical literature says about their risks? Has anyone ever talked to you about this before? Oh, that's really good to know. Okay, so you've been on these for a while, but you don't feel totally clear on the risks. Okay, I would love, so you and I are on the same page, for you to know what we think some of the risks are. And again, this comes from the medical literature. So there's a couple of studies that tell us that actually these may, it may seem to increase the risk of getting dementia at a younger age. Yeah, so that's one of them. Another one is people start to have falls as they age. And then also benzodiazepines are weird. They can kind of sometimes, I know this sounds a little bit odd, but some of the evidence seems to suggest that they can cause depression over time, especially. Yeah, I know. Okay, so what do you make of that? Does any of that sound like something that is interesting in your case? Or does any of this sound like something that you want to talk with me more about? So the idea here is to micro-consent. Can I tell you about this? Provide totally non-specific, generalizable medical information, and then ask the patient what is salient for them or how they took it in. And just for the sake of time, I'll just tell you sort of the benefits of this. Well, actually, no, for the sake of being a good educator, just think for a second, what are the benefits of asking the patient what they make of it versus just immediately assuming that they've taken away the same thing you have and that you're getting your point across. All right, so two primary benefits of this, and there's probably other ones I'm not thinking of right now, but the two primary benefits are that you then get to see what's landing for the patient. Oh gosh, I really don't want dementia. Oh, let's talk a little bit more about that. You get to see what feels salient for them, A. You get to understand what they're understanding of what you've shared. But B, it really changes the power dynamic and makes this into a conversation versus a lecture. When we elicit, okay, what landed for you, then suddenly we are having a dialogue about education versus patient education in which the patient hasn't necessarily integrated something and their experience was that they were being talked down to. You have created a dialogue, shared the same amount of information, but transformed the patient experience and allowed them to take in the information in a new way. And sometimes just validation and education can really, really transform the next parts of the conversation. And sort of a FYI for you all, when I see a patient on the first visit that's taking benzodiazepines, maybe they've been prescribed for a long time, I just never tend to it on the first visit, unless I have, if someone says, I need my benzodiazepines and I can find, no evidence that they've been on them historically, et cetera. I just don't even tend to it. But on the first visit, I might just do a little bit of education. Hey, tell me what you know about benzodiazepines. Is it okay if I tell you what I know about benzodiazepines? And then I might say something like, we're going to come back around to that. Was any of that useful for you today? The idea is I'm going to drop some seeds of education versus immediately potentially ruining the relationship with the person on the first visit. I'm just going to use some of these illicit tools to start sharing little tiny tidbits about benzodiazepines. And actually, there was a study a couple years ago that I loved. My dear friend, Sandra Rakesh, who I just adore, she references this study a lot, and I think it's such a useful study. Patients that were prescribed long-term benzodiazepines, I think it was in the VA, their providers did not ever talk to them about benzodiazepine cessation. Instead, they got brief, short educational mailings about the risks of benzodiazepine as they aged. And ultimately, those patients started asking providers to taper. The patients that got the mailings were, gosh, I want to say 7 times more likely to have tapered over 2 years than the patients that were directly educated by the provider in office, which shows you sort of the magic of these little drops of education where patients do not feel defensive or that the education is coming because there's a major threat on the other side. So these little drippings of education in first visit, second visit, before you even start a conversation of, oh, we're going to stop those, can sometimes be really, really powerful. And gosh, if you have the ability to do an intervention where you're doing these little mailings of education around benzodiazepines, then it turns out it's incredibly useful for patients. So I'm losing my voice. I just put in a lozenge. I hope it doesn't change the clarity of my speech tremendously. But the risk of me not putting a lozenge in my mouth right now is that I don't know that I would have a voice by the time 10:30 rolled around. So you're going to have to bear with me. Apologies. So at this point, probably many of you are saying, yeah, but Lydia, I validate and I educate. Maybe I don't do it perfectly with your illicit, provide illicit, but I do validate, I educate, I'm incredibly patient, and that doesn't work. And so I want us to sort of come to the next, what I would call tier of intervention. Difficulty of the conversation is getting a little bit trickier. And validation and education is not sort of getting you where you want to go. The next thing I'm going to ask that you do, and indeed, if you take one thing away from this talk this morning, this is the one thing. So if you've kind of been drifting off, if you're like me, you ran out of caffeine, this is the time to come back in. You are going to focus, and indeed, this is the biggest section of how to have these difficult conversations. You're going to focus on care and safety. If you remember, safety is the #1 principle of trauma-informed care. Allowing people to feel safe, even when we know we're doing things that feel threatening to their nervous system, or encouraging or focusing on safety, is almost always the way to go. So if and when these conversations get trickier and patients protest or emotions start to run higher, the first thing you do is you focus on care and safety. So this might look something like, as your provider, I care for you and your safety, and I don't think these medications are safe for you. So remember when I said during elicit, provide, elicit, you are very, very sort of general. When you start focusing on care and safety, this is a time where it's okay to see these medications aren't safe for you. Because unlike saying my license or clinic policy, this is a moment where you're going to start to really have a power imbalance. It gets trickier and trickier to be collaborative, but you still can focus your relationship on I as your care provider want you, my patient, to be safe. So it might look something like this. Patient says, I just really, really need my Xanax. I don't function well without it. I feel like you're not listening to me. It really works for me. Nothing else does. I have tried everything, and Xanax is the thing that I really need. A focus on care and safety might look something like this, and you'll probably hear some other tools in here too, but the biggest thing here is the focus on care and safety. You might say something like, I really hear you. It sounds like Xanax has really worked in the past. And as your medical provider, your safety is my biggest concern. I don't consider these medications safe to use on a daily basis. I think you deserve better than Xanax. I think you deserve to be safe, and I think you deserve to experience less anxiety, and I'm hopeful that we can get you there. You see how many times in there I use the word safety? So I'm saying a couple different things. There's some like hope here, there's some validation here, but in there, I said the word safety 3 times. I worry about your safety. Your safety is my concern. As your care provider or your medical provider, I care about your safety. So again, if there's like one thing to take away today, this is the thing. These conversations start to ramp up and patients have more and more emotions. We have more and more emotions, right? Transference and countertransference are so incredibly alive in these conversations. Focus on safety. The things that are true here is that safety is the biggest concern. And indeed, this also helps us to focus on transparency. Because when we're transparent, safety is the core reason that we often don't prescribe these. So when we say my license is at risk, what's underneath that? Oh my gosh, my desire to be in a huge room with all of you guys so you could be shouting answers at me right now while I eat a croissant is so big. I'm like, oh, I want to hear what you guys say about this. What's underneath all of the things that we often say to patients is actually safety. Like people lose their licenses because they don't safely practice. These medications, sometimes I'll hear clients say, oh, well, that can be addictive. Let's come back to why that one's a really tricky one. But sometimes you'll hear clients say, you'll hear clinicians say, these medications are addictive, and so I don't want to prescribe them. But what's underneath the concern about addiction is that the patient be safe, right? Or these medications are often diverted. What's underneath that is that we want the community to be safe. The reason that substances, especially controlled substances, are controlled is because they have a higher safety profile, right? So when we focus on safety, we are utilizing principle 1 of trauma-informed care. We're communicating our care, and we're really focusing our care in that relationship. Doesn't mean it's going to go perfectly every time or that every patient is going to go, oh, you care about my safety? Well, okay, then yeah, I totally get it. Thanks so much for caring about my safety. I'll see you in a month. I'm not saying it's going to like make these conversations perfect, but the other thing focusing on safety does is it is truly transparent. The reason that we don't prescribe these medications as liberally as we once did, and the reason that we have concern for them is because we have more and more knowledge about ways in which they're not safe for our patients. So we're being really honest. If it's about your license, it's actually about patient safety because they take away licenses from people that don't practice safely. And can I just say really quick that like 1 or 2 benzo scripts, sometimes new grads will text me and be like, if I prescribe this person's benzos for another month, are they going to take my license away? And I'm like, no. People's license get taken away when you're practicing in an unsafe way and you're not documenting risk-benefit analysis. People don't get licenses taken away for prescribing controlled substances. All kinds of people can prescribe all kinds of controlled substances, but they're clear about the safety risks of it, and they're tending to that, right? So again, when we focus on safety, we're being transparent. And then those pieces around addictive, and actually let's just focus on that one for a second. These medications are addictive. That's another one that I hear people use. And what they're trying to get at is safety. Like, I care about you, I want you to be safe, but the word that they'll use is addictive. And I'm just curious, what do you think the risk of saying these medications are addictive is? Just think about it for a second. And Paul, let me know if anything comes through.
I will. We did have one person ask if we might be able to track down the brochure that was being used by the VA in that study. That,
I can write
that would be a great resource.
Yeah, I can write to Dr. Rakesh, and I can see. I'll get it. I can get that study, and cool. I'll send it out to folks. Yep.
Right.
Yeah. I know, it's so cool.
We're getting some answers here now. Okay. You're an addict. One person says.
You're an addict, right?
You're an addict. It is pretty close to calling someone an addict. The patient might think that you think that they're an addict. Yeah. And it brings up their defenses, right? I'm not an addict. It's like,
Totally. The minute you use words like addiction, or even sometimes words like dependence, depending on sort of the health literacy of your patients, the minute you start using words like addictive, what patients hear is, you think I'm an addict. And immediately, like, this shame starts to activate the sympathetic nervous system. You get shutdown of your prefrontal cortex. And especially for our folks of color, our folks that are otherwise marginalized, this is such a heavy overlay and ruins and harms that relationship. And again, the concerns about neuroadaptation are very, very real. And so I would describe for patients the way in which neuroadaptations happens, right? Benzodiazepines cause neuroadaptation. It makes our cells need these on a daily basis, and it means that we're more likely to get withdrawals, and we're more likely to have anxiety, and indeed unmanaged anxiety and depression over time as our cells get used to having these medications around all the time. Talking about addiction just immediately pulls I'm an addict, I'm a criminal into the conversation. And indeed, the one that's most likely to, I think, make people feel like a criminal is these medications are often diverted. So I'll hear some providers say well, I just tell people that they're diverted, so I have to be really careful with them. And I'm like, well, I kind of like that. Yeah, I have to be really careful because I'm worried about community safety. But if you start throwing the word diversion around regularly, then what patients are going to hear is you don't trust them and you think there's some criminality going on here. And sometimes that's true. I am sure that my patients divert some of the medications that I give to them. I do everything in my power to try to decrease diversion. I certainly would never want the DEA to think that I'm pro-diversion of anything. And the patient in front of me's safety and the community safety is so much more important than my concerns around criminality, right? What I'm worried about is the patient in front of me's safety and community safety. When medications get diverted, that's when we know there is riskier med interactions, we've got more risk of overdose, etc. So what I'm actually talking about here is safety. And then this one, we've probably talked about it enough today, but it's worth just another call out. These medications are against our policy. This is such an easy one. It is so sort of available to us if we want to avoid a difficult conversation. And yet the patient experience of it is often, you don't care about me specifically, which is part of what I love so much about focusing on safety. Is that you just over and over again, as your medical provider, your safety is my priority. It focuses back on the relationship and your care for them. And again, this is the one that I want you guys to really, really take away. You don't have anything else to say, hey, that's not safe. And I use this all the time in the emergency room for all different kinds of reasons. Hey, the thing we're doing today, we have to do it because as your medical provider, I care about your safety. I find this to be incredibly useful in so many difficult conversations. And it doesn't mean that that is always going to fix it or make it an easy conversation. Focusing on safety is not always going to get you where you want to go. And so often in these moments, if safety isn't getting us to the place in the conversation that we want to be with the client, then what usually is coming up is like all these feelings for the patient. Remember, we are offering what is a very real threat to them, their experience of everyday safety, maybe their livelihood. So lots and lots of sort of threat response feelings are going to come up. And what I want you guys to do there is to tend to those threat response feelings, those like hard feelings. I want you to tend to them and not react to them. Our patients are often incredibly skillful human beings, and they know how to get their needs met, as they should. They've often been living in tricky situations with a great deal of adversity for a long time. And again, they're incredible at getting their needs met. And sometimes getting their needs met means they're going to try to pull us into an emotional reaction. And this is a funny moment because you'll always hear me over and over again saying that I think the way to avoid burnout is to bring moments of humanity into the clinical space, to find moments of humanity and these little glimmers with patients. That's one of my primary tools for avoiding burnout. But in these moments, I actually want you to be as clinical as possible. Tend to the feelings. Don't react to the feelings. And then respond as clinically as possible. So clinical responses might look something like this. The patient says, well, I hear that you want me to be safe, but like I can't work if I'm anxious. Do you want me to lose my job? Do you want me to be on the street? And a clinical response that's not a reactive response might say something like, I want you to have safety and anxiety control. It's in my medical opinion that your medicine won't give you that. See how like weird and clinical that is? There's almost no other moment where I would recommend it. But in these moments where feelings are really running high, you come back with clinical response. It's so common for patients. And you know, it's funny, I have these conversations much less now that I work in an emergency room than when I worked in primary care, embedded behavioral health. But during that time period, it'd be so common for patients to say things to me like, well, like, Doc or Lydia, do you have anxiety? And, you know, it would be so easy for me to like have a shared moment of humanity where I'm like, yeah, I feel anxious all the time. Holy smokes, right? I'm scared about the world. I'm scared about my kiddo. I'm up at night sometimes because I worry so much. And in this moment, it is not the time for shared humanity, right? In fact, it's the time to be very clinical. Yeah, I do have anxiety sometimes. And I want every minute of our time today to be talk about your anxiety management plan. Super clinical response. Yeah, I have anxiety, but today's visit is for you. Or sometimes patients will say something like, I wish you could feel my pain, or I wish you could feel my anxiety, or I wish you could feel what it's like for me if I can't concentrate. And this is a good time to say, I know you're suffering. I want to offer some clinical interventions so that you suffer less, or that we can decrease your suffering. Or I want to offer some clinical interventions that ensure that you're safe. The idea here, again, is to sort of not get roped into this potentially very reactive moment, but continue to focus on safety and helping them feel better in a very clinical way. Other things that sometimes get said, and just some like potential responses, because I want you guys to have some examples of this. And actually, you know, it just occurred to me that this is a good time, if you want, to put into the Q&A things that you've had a really hard time responding to, that patients have said to you in these moments, that you've really, like, you don't know how to sort of navigate it. And I got to tell you guys, there's a couple that I don't know how to navigate either, but put them in the Q&A so that we can sort of workshop it as a group in terms of like, how do you respond to that kind of stuff? Patients have said things to me before about like benzos, for example. Is it legal for you to let me go into withdrawal? Okay, I'm going to taper you safely. My intention is to keep you safe and to not harm you. Or patients will say things, this is common, like if I don't think that stimulants are clinically indicated, or I don't think stimulants are safe for someone or safe for the community, people have often said to me like, well, then I'm just going to go use meth. And my response, again, trying to be as sort of clinical in this moment as possible, is something like, I really hope you don't use meth because I really want you to be safe. If you think that you are going to go use meth, then let's talk a little bit about how to do that more safely. And I have like a whole spiel on methamphetamine related harm reduction. I don't usually go into it right now, but I can. If someone sort of threatens, although I'm not crazy about that as a framework, if someone says like, I'm going to do this if you don't do this, then what we can do is dive into harm reduction for the thing that they are telling me they might do instead. I'm not going to get sort of roped into like, no, please don't do that. Like, okay, in that case, then like we can do this, right? I've made a clear clinical decision and I'm going to stay sort of grounded in my clinical decision making. Another thing that comes up and is so tricky is mention of suicide. So if you don't give me these medications, then I will kill myself. And this one is just so tricky. And I wish in some ways that we were all together, because I would love to hear how you guys navigate this. And how I navigate this is I pretty quickly go into like a fairly clinical suicide risk assessment. Hey, tell me more about those thoughts. Have you gotten to the point where you think about how you would do it? How much time have you spent doing it? Do you think that you need to go to the hospital? This is a place where, again, you get very clinical and it's really, really stressful. And the response is not going to be then to change your clinical decision making because some of these hard feelings are coming to the surface. I've also been told things like, I'll get a lawyer or I'm calling CATU. And my response to that is like, please do what you think is right. I'm going to do what I think is right. And my hope is that you do what you think is right. If you need to involve a legal team, do it. I'm still going to provide what I think is the best clinical care for you. So I'm sort of disengaging, clear boundaries, bringing in a clinical lens. All right, before we move on to the next one, what are some things that people have said before that, what are some things that people have said before, or what are some things that people have heard before that have been really hard for you to navigate?
Here's one. You think your evidence tells me more about me than my lived experience. I am not a number. Yes, I know that is what research says, but I am not a data point. Patience is implying that the evidence I share about research and EBP is more meaningful than them telling me about their experience.
Yeah, this is such a tricky one because they're right? We have population, we have basically population level data, and we have some RTCs around this, but we don't know what their patient experience is. We don't know what their everyday life is like. And it's a place where we really have to think about sort of risk benefit. And what I tend to tell people in this moment is, as your medical provider, I have to rely on the evidence. And you and I can do this collaboratively, but I have to rely on the evidence for what I think is safe. What I think is safe for you. Yeah.
This person says that they find that so many LIPs having such a hard time in an ED setting not keeping the patient after they said, if you don't do this, I'm going to kill myself. It increases workload for the whole team and emotional burnout and frustration for the LIP CIS.
Oh, sorry, go ahead.
No, I was just, you want to read that back again?
Yeah, I just wanted to make sure that I understood what the role was of the person who was saying it.
I find so many LIPs having such a hard time in an emergency setting not keeping the patient after they said, if you don't do this, I'm going to kill myself. And that it increases workload for the whole team and emotional burnout and frustration for the LIP CIS.
Yeah, such a good question, and also so tricky because what I hear this person saying is that they are then the person that the patient is referred to when they've endorsed suicidality. So like that clinical assessment and then referral to the emergency room. Now this is the clinician in the emergency room. The good thing is the clinician in the emergency room should be super fluent in risk assessment for suicidality. And we know that secondary gain is part of what we take into account when we're thinking about suicide risk. And so we can really frame back for the patient, I really want you to be safe. I really want you to be safe. If you are feeling at high risk of suicide, if we can't figure out a safety plan, whatever it is, I'm going to ask you to stay. And if this is primarily about secondary gain, and that's what my clinical assessment says, then I am going to hold the kindest, strongest boundaries around not providing these medications. And so for the sake of time, let's jump to the next one. And I just got a text message, thank you, Paul, saying that actually we don't have until 10:30, we only have until 10. So that is fully my bad. So I'm gonna wrap us up sort of quickly here on the final piece, which is just providing really, really clear boundaries. As these conversations get trickier and trickier, there's sort of is what I consider to be like the final intervention. It's just these very, very clear but kind boundaries. If you're fluent in DBT, this is going to feel like second nature to you. And it looks like this. These medications are off the table. We are no longer having this conversation. How else can I be of service to you today? Or there's nothing else you can do or say to make me prescribe this medication. What else would you like to talk with me about today? And I will often say off the table. If you ever work with me, you will hear me say that's off the table. And then I'll say, let's talk about other options, because I still believe in voice and choice, but I can say this is the thing that's completely off the table. I leave it pretty far. I don't start my conversation with this is off the table. I do some elicit, provide illicit, and a lot of validation and a lot of focusing on safety. And then if things are still going, are still sort of ramping up and getting intense, and whether it has to do with benzodiazepines or stimulants or someone in the emergency room that's not taking a medication, I'll say that's off the table. What could we do to make this feel better? Or how else can I be of service today, depending on the clinical situation. But the idea is that at some point I just say no. And at some point I even say no, and we're not going to talk about this anymore. This is off the table. I'm going to remove myself from this conversation because that's not on the table. I do want to be of service to you, but XYZ is no longer something we're going to be discussing. And that's where I tend to leave it, because, you know, folks can sometimes get really circular, especially when they really, really think that their safety is being threatened, which it often is if we're taking away medications that most people feel like are incredibly salient and provide a whole lot of relief. So I apologize that I sort of wrapped us up really quickly at the end there.
There were a couple sort of late additions to respond to your last couple of points. Also, Lydia, I wanted to, when you were saying, what are some hard things you've heard? One was, you've been prescribing this for me. Why are you stopping now? I think that's a difficult one, right? And then I think this one is like where the person, the sense that they feel like they're being lumped in with the bad people and that they're trying to express that they're not the bad person, right? The patient says, I've used Xanax safely for over 20 years and I've never refilled early. It doesn't interfere with my life and it actually helps me survive my panic attacks. It's like, that's they're bringing all this evidence to you about, why they're different.
Yeah, so tricky. And, I have so many thoughts to that because I actually am someone that prescribes benzodiazepines a little bit more liberally than other folks. I will use PRN benzodiazepines. I believe in a benzodiazepine legacy patient. If you have a patient that has had no aberrant behavior, there's no risk of a substance use disorder, they're not incredibly aged at this time period, it may be appropriate to continue. And more often than not, there's some safety concern or we wouldn't be continuing. And so, we wouldn't be having this discussion. The way that I like to frame it when patients say, I've been taking this for years and I don't have any problems with it. I've been taking Oxy and 6 milligrams of Xanax totally fine for 15 years. What I'll tend to say is that is so good for me to know. I love thinking about how responsible you are with your health and your medications. I think about this as being sort of like driving without a seatbelt on. So you could probably drive without a seatbelt on, 199 times out of 200 and you'd be fine. But driving with a seatbelt on is best practice because it keeps you safe. And as your medical provider, I want you to be safe. So I think of this prescription as sort of like driving without a seatbelt on. Ultimately, for you long term, it's not what I think is best for your health. So I love that seatbelt analogy because we do take on some risk benefit in medicine. This is the time where we've decided that the risk is such, it's not going to be tomorrow. It's not like, oh, I prescribe you Xanax and like tomorrow something bad is going to happen. We are thinking about long-term risk of bad things happening. And that's the same as driving without a seatbelt on. So sometimes for some patients, that's a useful way of thinking about it. Long-term risk benefit and what makes us safer. There was one other one in there that you mentioned, Paul, that I want to tend to, but I can't quite remember what it was. What did you say right before I've been on these 15 years?
You've been prescribing this for me. Why are you stopping now?
Oh, really, really good question. And I just try to ground it in safety. And sorry if I'm sort of repeating this over and over, but I just think it's so useful to find ways to thread safety in on a regular basis. So I've been prescribing these for you, and I'm always thinking about what's best for you. And given sort of a couple of things that have happened recently, I'm starting to think about these as not being as safe. Would it be okay with you if I tell you about the things that I've been thinking about recently that make me feel like this isn't as safe right now? And then the patient will generally say, yeah, I'm happy to hear it. And then you get to do a little bit of patient education there. But the idea is you keep coming back to like, this is about safety. And something recently has made me rethink safety profile for you.
That's great. That's really helpful, I think, because it's like, that's the anchor, right? Is, bottom line is your well-being is what we're focusing on. And,
Yep.
Let's
yeah.
Don't get distracted by the other things. So.
Yep.
Yeah,
you guys, I'm
great.
so sorry that I got our time mixed up. I will hang out a little bit beyond 10, but also I want to be so mindful for people that have to like jump back into clinical schedules at 10. Feel free to go whenever you need to go, and I'll just hang out for a couple more minutes and do questions. That work for you, Paul?
That's great. And I just mentioned too, if anyone's about to chime off, just a couple of final things just to let you know about here, and we'll continue to leave this open for Q&A for a little bit, but as soon as we're done here, you will find an email for you from me that has all of the various options you can select to get your CME credit or CEU credit today, whatever that you need, as well as a copy of the presentation slides so you can refer to those. And you'll have all that later this morning. The only other thing I would just mention is we are developing for Q2 So sometime in the April, May, June neck of the woods, our next session is going to be on medication for opioid use disorder. And we haven't covered this specifically in a couple years. So it's really overdue for an update. And we decided that it would be fun to, in addition to best practices, do a little myth busting about MOUD as well. So I think that should be great. So be sure to get on our distribution list and watch for that, in addition to other sessions that we're developing this year, including one on gun violence as a public health issue that we're looking forward to presenting to you. So we've got that in the hopper as well. I just want to thank everybody for joining us here today, especially Lydia, for being so gracious and generous with her time and expertise. And of course, to the great Ian Youngstrom, our video producer par excellence, who keeps us above water, even when we hit some swells, which is always awesome. So thank you, Ian. And I'm just looking through, here's one, a really blunt question observation as a non-prescriber, Lydia. Isn't there a risk of prescribing some of these medications very short-term in what you feel is an appropriate way, that the patients will get the impression that prescribers will only do short-term, and therefore they seek care elsewhere and they get perceived as doctor shopping and have a negative experience?
Let me see if I can say this back to make sure that I got it. So in terms of prescribing very short prescriptions, that you're sort of propelling people towards doctor shopping, yes, I think that there certainly could run the risk of that. This might be in response to me saying I give people little bits of benzodiazepines. And let me be really clear that when I give people small amounts of benzodiazepines, I tend to do that for people that are benzodiazepine naive. So not someone that I think that has a benzodiazepine use disorder. If someone has a benzodiazepine use disorder, I'm not going to prescribe them benzodiazepines unless I'm helping in the withdrawal management process. But if someone is benzo naive, I tend to be someone that gives someone, 4 Ativan a month if they've got bad anxiety. And some providers just don't want to do benzos at all. And I really think of benzos as this amazing, complex, double-edged sword. So I know I said this was a discussion about discussing and not prescribing practices, so I'll keep it short, but benzodiazepines are not bad. They cause neuroadaptation. They can become a substance use disorder for some people. They have long-term risks, and they're incredibly effective. And so for the right patient, they should not be off the table as something that is available to them. I hope that clears that up. I don't want you to think that I give little bits of benzodiazepines to patients with benzodiazepine use disorder and then encourage to go see a different provider.
And I'm just seeing if we have any other questions here from our audience. I think folks might be jumping out because it's the top of the hour.
Yeah,
here
going to clinic.
Which wouldn't surprise me, but this has been phenomenal, Lydia. And any chance we ever have to be able to get a hold of you and benefit from your expertise is always a good one. But we had a huge attendee group here today. This went really, really, really well. People were super engaged. I don't know that we've ever had as much use of the chat before as we did today. People had a lot to say, and you're just so great at letting them feel that they can be heard and express themselves. I think that's a rare thing. Any tips on what to say if a patient has already tried everything else?
This is such a tricky one, and patients will often say, I've already tried everything else. And it's such a bummer because benzodiazepines really do work in a way that other medications don't. And so then we're sort of mitigating what people are expecting from medications. And we're going back to the drawing table in terms of what people can expect, realistic anxiety reduction from other types of medications or other behavioral interventions. And it's tricky. It's very, very hard. And it's a good question because it comes up frequently.
And the questions are turning into phalanx of compliments for you, my friend. So everyone's just really grateful for
Okay.
this and appreciative. So I think we might be out of the Q&A window here. And again, if folks have any stray questions, you can always hit us up by email and we'll take care of things for you here. Again, folks, watch your email today and you'll be getting an email with all the instructions and links to go ahead and apply for your credit, whatever you may need, and copy of the slides and everything like that. And I think at this stage, the best thing for us to do is give a huge round of thanks to Lydia for this phenomenal presentation here today. It's going to do a lot of good for our members and for the community throughout Oregon and beyond. So really, really appreciate this, my friend. Thank you.
So happy to be here.
All right, folks. Well, thanks for joining us here today. I think it was worthwhile. I think it might be 2 or 3 degrees warmer outside now. Still pretty cold as February can be. So take care of yourselves. Thank you for your time. Watch for your emails. And on behalf of us all here at CareOregon, thank you so much for everything you do for our patients and the difference that you all make. We really appreciate you. And we'll see you next time. Thank you.